Okay. I'll start the session.
Anil sir,
Yes.
over to you. You can start, sir.
It is not audible.
No, sir.
It's
Not.
audible.
We can hear you, sir.
So your presentation is not audible yet, sir.
Okay. Can you hear now?
No, sir, not yet.
We can hear you, but no
Can't see
sharing
the-
of the screen.
Yes.
We can't see your screen.
Sir, do you want me to do it from my end? Sir,
Yes, you can do it from your side.
Aarti, you do it.
Yes, sir. So, good evening, everyone. I welcome you all, and we'll start the session with Dr. Anil sir's welcome address.
Respected seniors,
Is it audible?
colleagues, on
Yes.
behalf of International Society of Manual Small Incision Cataract Surgery, I, Dr. Anil Shah, President for Maharashtra chapter, welcome you, all the delegates, speakers, discussion on this wonderful series of webinar that is A to Z of Manual Small Incision Cataract Surgery. Today is episode 4 and we have a very basic topic, know your surgical instruments. A surgeon is always a true leader. A good surgeon works on the patient in the operation theater with various kinds of surgical instruments. A true leader needs all leadership characters that can handle variety of surgical tasks effectively. One-way leaders are obvious failures. Basically, there are 3 types of instruments. Simple instruments, a ready set of instruments to tackle basic surgery. Special instruments to deal with modification in surgical technique. And complication managing instruments to deal with complication that occurs during surgery. And for today's topic, that is know your surgical instruments, we have speakers who are expert in their field with the best of their knowledge and experience. Dr. Rujita Bajwe, Dr. Arpit Shah, Dr. Rohit Modi. And to discuss this topic, we have expert panelists, Dr. BNR Subudhi, Dr. Subhangi Sathe, Dr. Avinash Ingole, and the world famous Dr. Neto Rosatelia from Brazil. So for this series of webinar, our aim is to popularize smart SICS. It should be safe, cost effective with minimum learning curve, and it should be useful for community basis. So our mission is to conduct series of webinars to enrich the knowledge, to popularize SICS from basic to advanced, to give recent advances to postgraduate students and practicing ophthalmologists, to involve expert surgeons to share their experience and knowledge, to make SICS interesting and a popular technique. I am once again thankful to all of you for making this webinar a grand success. Thank you very much.
Thank you very much. Aarti, you can continue.
Yes, sir. So I welcome you all once again to this wonderful session, which is episode 4 of webinar series A to Z of MSICS, Know Your Surgical Instruments. So we have with us ISMSICS office bearers. So we have with us Dr. Amulya Sahu sir, who is founder chairman of ISMSICS. We would like to hear Amulya Sahu sir's word of wisdom. Over to you, sir.
Well, as I told that Anil is doing a great job. I'm very, very proud of him and one of our original thinkers, and he has done a great job.
Thank you,
And
sir.
Nato Rajutali is here, and he is almost, we feel he is such a wonderful human being and surgeon par excellence and a legend in making and very comfortable to deal with, and he's an excellent teacher. So we are really, we feel so happy that whenever we meet or see him, and he's almost a part of us. So welcome, Nato. And it is a, I think the session will go in a long way now. So Anil, I'm proud of you.
Thank you, sir. Thank you very much, sir.
Thank you.
Thank you so much, sir. Next, we have with us Dr. Jagannath Boramani, sir, who is Executive Chairman of ISMSICS. Over to you, sir, for a few words of wisdom.
Yeah, good evening, all of you. The team Maharashtra chapter of ISMSICS under the leadership of Dr. Prakash Marathe, Dr. Anil Shah, and Dr. Amey Kulkarni are really wonderful, doing a wonderful job. There are multiple episodes, 12 episodes in 1 year lined up, covering different aspects of MSICS, and every Wednesday, one Wednesday in a month, each topic of SICS is thoroughly discussed. We have got expert speakers today and expert discussants, including Dr. Neto Razatelli from Brazil. I think we'll have a wonderful time today with a lot of discussion. Over to Aarti.
Thank you so much, sir. Next, we have with us Dr. Parikshit Gopte, sir, who is Vice Chairman of ISMSICS. So over to you, Parikshit, sir.
Thank you, Dr. Aarti. As Dr. Boramani sir said, Dr. Marathe, Dr. Anil Shah sir, and Dr. Amey, between them, they have really set the ball rolling for this chapter. And here we have three very dynamic speakers, Dr. Ruchuta Machwe, Dr. Arpit Shah, and our own very Dr. Rohit Modi, who will be speaking on the various kinds of instruments. Now, I mean, you cannot win war without having good weapons, and we cannot do great surgery without great instruments. So how to take care of them, which instrument to use when, I think that is something that we will learn today. And of course, the icing on the cake is having Dr. Rosatelli here. I mean, he's an international star, a living legend from Sao Paulo, the largest city in the Southern Hemisphere. And he's a star not just in the Latin American countries, but even in the American Academy and now in India. And yeah, we love him a lot in India, and he has been so generous giving his time and his expertise to us. So thanks once more to all the speakers and the panelists.
Thank you so much, sir. Just to mention here, it's afternoon for Dr. Neto, and he has really adjusted his schedule for surgeries just to be in this session. So we are really grateful to you, Dr. Neto, for taking time out for us. So other office bearers of ISMSICS, Dr. Satanshu Mathur, sir, as Chief National Coordinator, Dr. Barun Nayak, sir, as President, and Dr. Deepak Mishra, sir, as Secretary of ISMSICS. They'll be joining us shortly. We have with us Dr. Prakash Marathe, sir, who is Chairman of Maharashtra chapter of ISMSICS. So we would like to hear from you, Prakash Marathe, sir.
Thank you, Dr. Aarti. I think it is the wonderful webinar going on with great efforts of our President, Maharashtra chapter ISMSICS, Dr. Anil Shah. It is the leadership by Dr. Amulya Sahu, who is the founder chairman, then Dr. Jagannath Boramani, the working president, working chairman, and Dr. Parikshit Gopte as vice chairman. And our team of Maharashtra office bearers, who everybody of them, they have been working very hard, like Secretary Ameya, and Dr. Anand Pangarkar, chairman scientific committee, Dr. Usha Zori, then Dr. Rajesh Doshi. And today we have got speakers. What we have decided that so many speakers are there, but we identify even the juniors to seniors, and from all parts of the country. And whosoever is interested, we are involving them in this particular scientific session. Dr. Anil has designed this particular A to Z session in a very nice way. And nice to see Dr. Avinash Ingole. And icing on the cake is Dr. Neto from Brazil. Nice to see Dr. Neto here. And my friend Dr. Bienar Subodhi is also there. So all chairpersons, speakers, discussants, and all office bearers of ISMSICS, I welcome all of them. And this is the vibrant Maharashtra chapter at present working very hard. And I'm very thankful to all office bearers to appreciate the work of Maharashtra chapter. And let's continue this particular process over the year. And all the webinars definitely will be successful. Over to you, Dr.
Thank you, sir. Thank you, Dr. Prakash Marathe. It is because of you we could do all these things. You're the first person who guided me how to conduct, and then after that, it has become a successful type of webinar. Thank you very much, sir.
Thank you.
Yes.
So thank you once again, everyone. So without further delay, we'll start today's session. Over to you, Dr. Rajesh Joshi, sir.
Yeah, thank you, Aarti. It's a pleasure to introduce today's speakers. I will just share my screen. I think
your screen is visible.
Yes, it's visible. Yeah.
From my side. Yeah. The screen is not moving. Yeah, regarding today's webinar, Know Your Instruments, we have 3 speakers. And the first speaker is Dr. Rujuta Machwe, who is the director of Machwe Hospital, Pune, and she's a consultant ophthalmologist at Dr. Tarabai Limai Hospital and Atharva Netralaya. She was the honorary secretary of Pune Ophthalmological Society from 2020 to 2021. She is executive committee member of MSICS Maharashtra chapter and invited faculty to almost all the conferences like POS, MOS, and AIOS. She is alumni of BJ Medical College and AFMC Pune, and she has won gold medal during her MS exams. She is passionate about dancing and has won Best Dancer Prize in various competitions held by IMA and LBO. Second speaker is Dr. Rohit Modi, who has done MS and DNB FRCS. He's a fellow of LVPI, and he's doing a great work in retina. And I think he's a perfect choice for vitrectomy. Welcome, Dr. Rohit and Rujuta. Third speaker is Dr. Arpit Shah, who has done MBBS from Pravara Medical College, Loni, and MS from MGM Institute, Aurangabad. He has done his fellowship in cornea and external diseases from Disha Eye Institute, Kolkata. His area of interest is microincision cataract surgeries, that is FICO, as well as small incision cataract surgery, refractive surgeries, and his special interest is in various types of keratoplasties. With this, I introduce to you our speakers, Dr. Rujuta Machwe, Dr. Arpit Shah, and Dr. Rohit Modi. I further invite Dr. Rujuta Machwe to give her talk on instruments, which are very essential while performing small incision cataract surgery.
Thank you. Sorry for the interruption. Before we go on to the speakers, Dr. Amay, would you like to introduce the discussant, and we can have few words from them as well?
Yeah, sure. So I'm the one who stands between you and an academic feast. So we'll have a quick introduction of our speakers. Today, we have a star-studded list of people who are going to discuss. So first and foremost is Dr. Neto Rosatelli. He's a lecturer and collaborating professor at the Department of Surgical Optics Cataract Sector of the Ophthalmology Department of Universidade Federal de Sao Paulo. And he's also a lecturer and collaborating professor at Department of Ophthalmology of the Faculty of Medicine of Ribeirão Preto of Universidade de Sao Paulo. He's a very high volume cataract surgeon and is under the contract for the Brazilian public health system in 12 states since 1998. We all know Dr. Neto Rosatelli for his fantastic skills and videos that we see in AO. So welcome, Dr. Neto, and a very good afternoon to you. The next discussant would be one of our very own Dr. BNR Subuddhi sir. He's from Orissa. He's chairman of Ruby Eye Hospital, Behrampur. He's been a member of managing committee of AIOS. He's a past president of Orissa State Ophthalmological Society. He's also chairman ISMSICS Orissa chapter. And Dr. BNR Subuddhi has a special interest in community ophthalmology and does a lot of work in community ophthalmology. Our next discussant is Dr. Avinash Ingole. He is a professor and head Department of Ophthalmology, St. GS Medical College and KEM Hospital, Mumbai, one of our most premium institutes in the country. Our fourth discussant is, it's my fortune to be able to introduce my own professor, Dr. Shubhangi Sathe. She has done her MS Ophthalm from Sarojini Devi Eye Institute, Hyderabad. Right now, she's the HOD SMBT Institute of Medical Sciences, Igatpuri. So welcome all of you, and we'll go ahead with our academic feast. Thank you.
I think few words just to name chairpersons. Yeah.
Sir, Prakash Marathi, sir, you can go on, sir.
No. About chairpersons, you please mention. Like Dr. Mandar and all, Dr. Usha Zori. They are the chairpersons today.
Yes, sir. So we have with us Dr. Prakash Marathi, sir, Dr. Anil Shah, sir, Dr. Mandar Paranspe, sir, and Dr. Usha Johri, ma'am, as the chairpersons. Dr. Usha Johri, ma'am, is Joint Secretary of ISMSICS. And ma'am, over to you for a few words.
Very good evening to all of you, and thank you for having me here. I think it's very, very interesting. This is our, I think, fourth webinar. And, I congratulate, all our team members, and a special, thanks to Dr. Anil Shah for having taken such sincere efforts to have this, a teaching program, which is not just for postgraduates, but I think it's for senior consultants, for all the professors and all the teachers, and for all the ophthalmologists. So thank you, sir, once again for having me. And over to Dr. Aarti.
Yes, we have with us Dr. Mandar Paranspe, sir, who is Vice President of Maharashtra chapter of ISMSICS. Over to you, Mandar, sir.
Thank you, Dr. Aarti, for the invitation. Congratulations to Dr. Anil Shah for the stupendous efforts that he has taken. And congratulations to all the speakers and the panelists. And without any further ado, I think we should go ahead with the presentations.
So maybe we can just get started with the talk now. So just a quick reminder, each speaker has 10 minutes for their talk. And reminder for the audience, if you have any questions, you can put in the chat box. If in case you are on web portal also, you can put your questions and we will take them towards the end of the session. Thank you. Over to you, ma'am.
Yeah, is my slide visible?
Yes, ma'am.
Yes.
Respected seniors, colleagues and dear friends, I welcome you all for this fourth episode of ISMSICS Maharashtra chapter webinar. I'm Dr. Rujuta Machwe, and at the outset, I would like to thank Dr. Anil Shah sir for giving me this opportunity. Before I proceed, let's start with worshipping the goddess of knowledge, that is Goddess Saraswati. We all know that cataract is the most common cause of curable blindness worldwide. 75% is in the developing countries. So to reduce this cataract backlog, manual SICS plays a very important role. Why? Because it is cost effective for the patients as well as the eye surgeons. It has a short learning curve and feasibility in almost all types of cataracts. Astigmatism, which was the main concern previously, is taken care of by the modifications in manual SICS procedure. So let's relearn and discuss about basic surgical instruments, surgical blades, cannulas, sutures. Every SICS surgeon needs from day one. Though they are basic instruments, they have to be of good quality for good surgical results. Starts with eye speculum. Weightless wire speculum, which is very light in weight, causes less pressure on the intraocular tissue. Rigid adjustable speculum having a spring action, 2 screws to adjust the 2 limbs, which is usually helpful in deep sockets basically. The superior rectus holding forceps, the tooth is shaped with a double curve near the tip. The tip is 7.7 millimeter from the fulcrum, which is the distance of superior rectus insertion from the limbus. Superior muscle with its overlying conjunctiva is grasped with the superior forceps while passing the bridal suture. In case of temporal SICS, the same thing is done with the lateral rectus. It is made sure that the whole of the globe moves along with it and not just the conjunctiva. The superior rectus suture needle holder to pass the bridal suture under the superior rectus muscle. Mosquito artery forceps is used to secure the bridal suture to the head towel. Superior rectus bridal suture ensures that the globe moves downwards and the superior part is exposed for making a proper sclerocorneal tunnel. The globe is stabilized to ease the process. Sometimes inferior rectus muscle suture is taken in addition for stabilization of the globe. Bridal suture also provides counter traction during the nucleus delivery. Lem's forceps is a tooth forceps for making conjunctival flap to hold conjunctiva, to hold cornea scleral edge during dissection, and if suturing is needed for the sclerocorneal tunnel. Conjunctival scissors are stout blades, slightly blunted points to avoid blood in globe injury. It has got a spring action to guard against excessive opening, and it is to make conjunctival flap at the site of main incision. Cautery. This is to control bleeding from the conjunctival vessels so that the sclerocorneal tunnel formation becomes easier. Then for conjunctival closure at the end of the surgery. Thermoballpoint cautery, it has a copper ball which, when heated, stores and transmits heat to the tip. Hemostasis is achieved by thermal coagulation. In case of bed-filled bipolar electrocautery, the tissue is coagulated under the irrigation solution. The current passes from one forceps to the other, coagulating the tissue held. Use of vernier calipers, it is to measure the distance of the initial groove from the limbus, which is usually 2 millimeters behind the limbus, and the length of the incision, which may be 5.5 to 7, depending upon the nucleus grade. BP handle, according to the preferences, number 11 or number 15 grades can be used. Tissue holding forceps, they are non-traumatic to grasp the ocular tissues and to fix the globe to facilitate the surgical maneuvers. Recent knife, it's a beveled knife mounted on a plastic handle, has 45-degree angulation, blunt rounded tip with sharp edges on the sides. It has a cut splitting action. It is basically used for creating sclerocorneal tunnel by wriggling movements and lateral swapping movements. The tunnel is extended 1.5 millimeter into the clear cornea. Lance tip, it's a 15-degree side port entry blade. It is a thin, straight knife with 15-degree sharp pointed tip, and cutting edge is there only on one side. The width is so as to cast 20-gauge instrument. It is used for creating a clear corneal side port incision, for performing capsulorhexis with cystitome, injecting trypan blue for anticapsular staining, viscoelastic injection for AC formation, and dialing the lens nucleus and intraocular lens. Cystitome. It is made up of 26-gauge half-inch needle. It has got two bends, 120-degree at the hub and 90 at the bevel. It is used for doing anterior capsulotomy, either CCC or can opener. Utrata capsulorhexis forceps are angulated with sharp tips, which are perpendicular to the body. These are used for capsulorhexis and anterior capsular tag removal from the AC. Kerato is a diamond-shaped angulated knife with a sharp apex and two cutting edges. The width may be 2.8 to 3.2 millimeters. We use dimple down technique to enter the AC, as we all know. Once AC is entered parallel to the iris plane, the tunnel is extended with a forward cutting movement. So now what we get is that sclerocorneal tunnel formation is triplanar. First perpendicular scleral incision is by 15 number blade. Second horizontal incision through sclera and cornea is by crescent knife. And the third beveled incision through cornea in AC, which has a self-sealing property, is by kerato. Coming to hydrodissection cannula, 25 to 27 gauge cannulas are there, which have got angle tip attached to syringe filled with irrigation solution. These are used basically for hydrodissection, that is separation of cortex from the lens capsule, so that no cortex is attached to the capsular bag and there is no stress on the zonules. For hydrodeliation, that is separation of endonucleus from epinucleus, and side port closure by hydrating the surrounding stroma at the end of the surgery. Dialer or Sinski hook, angular fine hook with 90-degree bend at the tip, attached to a long round solid handle. It is used for dialing the lens nucleus and afterwards the intraocular lens while implanting it. Iris deposit is a non-traumatic smooth spatula-like with a rounded blunt tip. Bimanual technique of nucleus collapse into AC. It can be used for this technique along with the dialer in case of small pupils especially, and then to break the posterior synechiae. Wire vectis is a steel handle and there is a loop ending at the end, which is usually oval in shape. It is for nucleus delivery done with the help of synchronous movements of the bridal suture and the mechanical movement of vectors. We can use irrigating vectors also. Here, the mechanical movement as well as the hydrostatic jet of fluid through the syringe is made use of. There are 3 irrigation ports, as I think you can see in the figure also. On the anterior surface of the loop, 10, 12, and 2 o'clock. The posterior body is connected to the syringe with irrigating solution. Simcoe cannula is basically irrigation aspiration of cortex or irrigation aspiration of cortex. You can see in the figure, in case of direct or regular Simcoe cannula, the aspiration is through the syringe attached to the silicone tube, and irrigation is through the irrigation line attached to the main central hub. In case of reverse cannula, exactly opposite is there. In case of subinstitial cortex aspiration, you can use J-shaped cannula. Eye holding forceps to hold the lens during the implantation. McPherson forceps are non-traumatic forceps to hold the trailing haptic of IL during its implantation and can be used for suture tying also. Vanna scissor is an angulated fine scissors with narrow blades for pupillary sphincterectomy, dissection of pituitary strands during the manual anterior vitrectomy. We'll just have a quick look, 2-minute video of all the instruments described. As you can see, the conjunctiva is held with limbs forceps, and stout conjunctival scissors are used for peritomy. Once the peritomy is done, you have to do cautery, either by thermoball point or like here, bipolar wet pay cautery. Excessive cautery is avoided to prevent scleral necrosis and to prevent astigmatism. You can use 11 number blade, 15 number blade, depending upon your preference. Incisions also, depending on your preference. Straight incision, frown incision, or straight incision with extensions, Blumenthal modification. So this is the first incision of the triplanar part. The second one is sclerocorneal tunnel. Here you can see crescent is used by wriggling movements, side-to-side movements, and especially we need to do side pockets so that the outer incision length is lesser than the inner incision length, so that the nucleus delivery is hastened and it is more easy. Side port in the plane of the iris for various functions as described earlier. This is the cystitome with 2 bends for capsulotomy. You can use trypan blue dye. You may or may not use depending upon your preference. And this is the keratome with dimple down technique. While going inside, you have to cut and not while coming outside, so that the incision inside incision is uniform. The corneal incision, which is the innermost incision, is uniform. This is the hydrodissection cannula for hydrodissection. You can rotate the nucleus with the help of Sinski or dialer as shown here. And you can prolapse it into the AC with the help of dialer. This is the vectis used, mechanical movements between the vectis pressing on the scleral lip and at the same time holding the superior rectus suture tightly. You can use irrigating vectis also as described earlier. And then the Simcoe cannula. You can see the tip is for aspiration and the side bore is for irrigation. Various cannulas as it described. This is the direct cannula for aspiration of cortex. And this is the lens implantation. The intraocular lens is held with lens holding forceps. And the trailing haptic can be held with the help of McPherson or directly dialed through the dialing hole with the help of the dial. Coming to the sutures, for superrectal bridal suture, 40 silk is used. Scleral sutures may be required in case of leaking sclerocorneal tunnel or premature entry, vitreous loss, unstable AC. And these are 10-0 ethylon sutures, which are non-absorbable, and they are on spatulated needle. The varicose needle holder is finely serrated needle holder and has got a spring action to hold the needle firmly and to bend the cystitome. There are 2 uses of this instrument. Then suture tying forceps, you can have straight and curved. These are non-tooth serrated or non-serrated. And as we know, in Mahabharata, Arjuna had his Gandiv Dhanush for winning all the battles. And here we have all the instruments for the surgical battle. Thank you.
Rutuja, nowadays we are not using this bridal suture.
Yes, sir, I know, but sometimes for the novice surgeon, it is a kind of, think that we can have that brittle suture and have a proper control on the glow. Yes, I know,
Yeah,
sir.
but in the beginners, also the teacher should teach them without the brittle suture because it creates its own problems.
Okay.
You know that. And second thing, what I noticed, you are giving almost a smiling incision, which is close to the limbus, and that creates more astigmatism.
Yes.
And
So basically,
it should
straight
be
or frown is advised, basically.
fine, at least 1 millimeter behind the limbus or 1.5 millimeter behind the limbus will be a good thing. Third thing, what I noticed, the side port, you should not use this flat blades.
Pardon, sir?
Try to use a MBR blade. Because in this case, what I tell now, if you are doing a flat incision and you are introducing your simple, that sort of, visco cannula or this thing, Simcoe cannula, then Descent separation possibilities are more because the wound is flat. It is not like a contoured sort of things. So those are the few points every teacher, now you are in a senior position, all these points should be integrated to your practice. And when you are teaching.
But like in my practice, I find side port very comfortable without any displacement at any time.
Long-term follow-up is necessary. And if you are doing really good follow-up, then you can produce paper and in our journal. Then you really have a good study. And that is necessary.
Okay, thank you for your suggestion, sir.
Thank you. Thank you. Otherwise, it's a good presentation.
Thank you.
Yes, Nato, any suggestion from your side?
Well, congratulations for the wonderful presentation, Dr. Rujuta. I think, it's a very good thing that I saw your presentation to get an idea. Well, I'm let's say spreading the word of SICS here in Brazil. Not many surgeons perform it, and the instrumentation is very, let's say, there are a lot of instruments that we don't commonly use in phaco, and most Brazilian surgeons that are getting into practice now, they don't learn how to do manual surgery. And so, well, I will take many points that you have stressed out in your presentation to help spreading the word of SICS here. We usually, phaco surgeons like me, we adapt a little of the instrumentation that we use for phaco emulsification, but because we have the phaco machines available, we don't do all SICS, only SICS surgeries during the day. We do phaco and sometimes we do SICS. So it's a kind of a mixed technique. Sometimes I use aspiration from the phaco machine, and because it's available, of course. But it's nice to be able to do, let's say, the surgery as a whole manual procedure, and so you have brought together everything that we need, and I'm sure you use it. Thank you.
Yeah.
Thank you.
Thank you, sir.
Thank you, Dr. Neto. Just a quick
Dr. Rujuta, I want to add a small comment.
Yes, sir.
Your instrumentation, everything is very good, excellent. And during surgical technique, I've seen the external incision a little bit larger. It could have been reduced to still smaller, and it could have made the frown incision. So probably you could have done the better way. So that's my comments.
Okay, sir.
Okay.
I think we are going to take question answers and discussion at the end of all three talks.
Yeah, I think,
so let's move forward.
Yeah, we'll move forward, and I invite Dr. Arpit Shah for his talk on special surgical instruments, pupil expanders, capsular tension ring for manual small incision cataract surgery. Yeah, Dr. Arpit.
Yes, sir. Good evening, sir. Good evening, all. Just give me 1 minute. not able to see my presentation.
Till the time Dr. Arpit is setting his screen, we have with us Dr. Anand Pangarkar, sir. He's Chairman Scientific Committee of Maharashtra Chapter of ISMS ICS. So, Ansel, if you are there.
Hello, everyone. Am I audible?
Yes, sir, you are.
Yes, sir. Yes.
Good evening, everyone. Very well done, Rujuta. And she spoke quite comprehensively. And the comments were definitely an addition point for all of us. Well done, the team, including Anil, Ameya, and you, Aarti, who work very hard.
Yes,
It's
thank
been
you.
so nice so far, and I hope we continue to do well. Good evening, Amulya House, sir.
Good evening.
Thank you so much, sir.
Presentation is ready, so please let us go ahead.
My presentation is visible, ma'am?
Yes, Dr. Arpit, it's visible. You just have, yes, we are good to go.
Right.
Yes, ma'am. Good evening, everyone. Respected seniors, faculty members, and my dear colleagues. At the outset, I would like to thank Dr. Prakash Marathe, sir, Dr. Anil Shah, sir, Dr. Usha Johri, ma'am, and everyone for giving me this opportunity and allowing me to express my views on today's topic. I'll be presenting on special instruments required during cataract surgery in SICS in FECO, both. So I'm Dr. Arpit Shah. Basically, I'm a cornea, refractive and cataract surgeon situated at Nashik. I will be covering non-dilating pupil and capsular tension devices. My talk will be on mechanical pupil enlargement strategies, capsular tension devices, Dr. Shahu sir's instruments for 2 mm SICS, Dr. Boramani sir's pre-chopper, and Dr. Anil Shah sir's snare. The surgical algorithm in managing small pupil cases should include topical and intraocular mydriatics, appropriately selected viscosurgical devices, and mechanical dilatation with instruments like iris hooks and or pupil expanders. So the purpose of this slide is to say that directly we don't have to jump to the pupil expanders. First, these mentioned points are to be tried, and then later on we can try. If that doesn't work, then pupil expanders can be considered. So mechanical pupil enlargement strategies will consider synecholysis, pupil stretching, iris cutting, and use of mechanical expanders. Synecholysis, release of adhesions in between the iris and the anterior lens capsule, can be done by iris repositors like instruments. Strongly attached pupillary membranes attached to the pupil and posterior iris surface can be identified. Gentle peeling with forceps help to enlarge the pupil. Pupil stretching. This photo I've taken from Dr. Uday Deogan sir's cataractcoach.com. So he is beautifully shown here 2 parasynthesis incisions and 2 instruments like Sinskey hook. They are stretching in 1 meridian to break the sphincters and help dilate pupil. This is again one more. So before and after is also shown here, and he's stretching pupil with 2 choppers. So few instruments I have shown here like Lister hook, blunt chopper, Fukasaka small pupil snapper, Sinskey hook, and Y hook like instruments. One of these can be used according to the availability. Iris hooks, 4 evenly spaced parasynthesis are performed and the hooks are introduced catching the iris edge. The sleeve of the hook is adjusted to expand the pupil to the desired size. Advantage are ease of manipulation. And wide availability of the hooks, and different sizes are available so that desired pupil size can be achieved. The drawbacks of iris hooks are iris sphincter tears and risk of bleeding. It is generally recommended not to extend the pupil over 5 mm in size to decrease the chances of iris tissue overstretching, producing irregular and atonic pupil postoperatively. So tiny pupil with synechia addressed with iris hooks. This image is shared. So there is a beautiful video by Dr. Saurabh Patrodhan sir.
Hello everyone. In this video, I'll be demonstrating and explaining some of the tricks.
I will like to show this video from this point, where now he has already done 4
This is to
paracentesis
avoid
incision.
any pain to the patient. When the iris hooks are inserted, there are various makes of these iris hooks, but they have a general structure which is in common, that there is a lock or silicone lock which is there. It's like a plug. So you have to first withdraw the plug towards its proximal end, and then once you put inside the iris hook and hook the iris, you have to push the plug so the iris or the pupil gets stretched. Now, just as you observe, I am not pulling this pupil to the periphery immediately. I have just hooked the pupillary margin and just stretched it slightly. I will stretch the pupil to desired size once all the hooks are in place. This avoids unnecessary pull on the iris and avoids pain to the patient also. So 4 iris hooks are now in place. Now I am going to stretch the pupil slowly. As you can see, all the 4 iris hooks are away from the main incision, which is at 11 o'clock or 10 o'clock position. So these iris hooks are basically placed at the anterior limbal or the mid limbal. Now I'm going to place 1 iris hook, for which I'm going to make a posterior incision.
So this is a very important point.
Why
here,
is posterior incision? Because when I'm going to use this main incision for inserting my phacoprobe, I don't want the iris to be pulled up at this position. So here the iris hook actually goes almost parallel to the iris plane. So when I pull this pupil towards periphery, the iris goes back rather than tenting up, thus avoiding.
I would like to stop this video here. I have shown what points I wanted to show. Will like to continue with my presentation now. So there is one Asia pupil expander. It is a pair of scissor-like disposable devices with blunt rounded tips and external spring mechanism. They are inserted through 1.1 mm side port incision located opposite to each other using specially designed forceps. The resultant pupil shape is square or slightly trapezoidal. And compared to the iris hooks, the number of incision necessary to achieve this pupil expansion is limited to 2 rather than 4. So now coming to pupil expansion rings, Malgin ring, BHEX pupil expander, eye ring pupil expander, and expand iris speculum. These are the 4 options. There are many options, but these are the 4 options we have right now. Commonly used options we have right now. So Malgin ring, currently one of the most popular pupil expansion ring is the Malgin ring. It is a square foldable device made up of polypropylene. The one-piece planar design features 4 circular curls located at equidistant point on the ring. The profile is thinner as compared to pre-existing rings, making it easier and safer to manipulate inside the eye. The device is injected into the anterior chamber and removed from the eye with injector system. The Malgin ring looks like this, and pupil dilation achieved is shown on the right side. Malgin ring, in contrast to iris retractor, creates a rounded rather than a square pupillary opening. The device is manufactured in 2 sizes, 6.25 mm and 7 mm. BX pupil expander, Dr. Bhattacharya pupil expansion ring is made up of 5-0 block monofilament polyamide nylon, available in square and hexagon shapes in various sizes, 6, 6.5 and 7 mm. It is a planar structure, inward facing notches located at the corners. These notches are used to fix the pupillary margin. Planar structure makes the device extremely thin, providing the advantage of implanting through 0.9 mm incision using specially made forceps to secure engage with the iris, to securely engage with the iris. So the BHEX ring looks like this, and the dilatation is achieved is shown on the right side. So these pearls, BX pearls, so keep anterior chamber underfilled with viscoelastics. Iris bowing helps in tucking of the flanges. Overfilling pushes iris against the lens capsule. Inject viscoelastic under the pupil margin to create space for flanges. Pupil rigid and less than 4 mm. Stretch bimanually before using BX. Fixation of the globe with side port instrument helps in manipulation. Attempt in the back delivery of the telling haptic of IL is important. So this video is shared by Dr. Bhattacharya itself, showing how to implant BX ring. With using these forceps, he has tucked the iris under the, and this way we have achieved dilatation of almost 5.5 mm. After implanting the IOL, he has taken out BX ring. So eye ring pupil expander, the Visite eye ring pupil expander is a single-use device made up of soft polyurethane. It creates a circular opening 6.3 mm in diameter. Four corners of the device create 4 channels that hold the iris in place and also adds to the stability of the device during surgical procedure. The device is assembled with injector used to insert and remove it. The device looks, the eye ring pupil expander looks like this. Again, the video by Dr. Saurabh Patwardhan sir will be showing how. I have never used this eye ring, but looking at the video, I feel that this eye ring expander is slightly thicker than BX available. BX ring available. So this way he has achieved dilatation. I would like to skip the removal part of it and stop video here only because of time constraints. So expand iris speculum. The new expand NT iris speculum by Diamatrix Limited is made up of memory metal titanium alloy. It is almost round, having even number of alternating side elements connected by arches. The speculum can be inserted and removed through a special injector by a special injector through a 2.4 mm incision, providing a near circular opening of almost 6.7 mm in diameter. A manipulator is used to facilitate placement of the device feet that catches the iris edge and expands the pupil. The iris expand, this expand iris speculum looks like this. I would like to avoid showing this video because of time constraint. The most commonly available rings I have already shown, so we'll like to skip this. Coming to the capsular tension devices, performing cataract surgery in patients with significant zonular weakness presents many challenges. The use of CTD, capsular tension devices, as an intraoperative aid increases likelihood of successful in the bag implantation of the IOL, and in many cases, complication of successful uncomplicated cataract surgery can be achieved. Indications for capsular retention device use: pseudo exfoliation, traumatic lens displacement, inherited cause of zonular weakness like Marfan syndrome, homocystinuria, and hypermature cataract, post vitrectomized eye, and intraocular neoplasm are the other causes of zonular weakness. The decision to use CTD is typically made at the preoperative visit itself. Standard capsular tension ring, known as standard capsular tension ring CTR. It is an open ring structure made up of PMMA and has an oval shaped cross section with eyelets at the both free ends. So this is a video showing a young female had history of blunt trauma due to firecracker injury, developed cataract, and was posted for cataract surgery after almost 6 months. So the almost 3 to 4 clock hours of zonular dialysis is seen here with fibrous capsule. The plan is to get a circular rhexis margin so as the hooks can be placed and the capsular hooks can be placed, and then CTR can be implanted to support the bag. So after starting the capsular rhexis, up till here, it was round and circular, but in the fibrosed area, we could not complete because of fibrosis. So I thought of using forceps, but that also was a little bit difficult. So 25 gauge retina scissors were used. The specialty of this scissor is this is curved, so that I could get a curved margin and did not get any ragged margins over there. So as I could put this capsular hooks there. Unfortunately, I had a FICO video for this show. So now CTR is being implanted. It can be implanted with one hand, or both the hands can be used. So Sinski can be held in other hand, and it can be placed in the back. It is advisable to use both hands. And this way, the cortex was removed and 3-piece IOL was implanted. Types of CTR ring. There are 2 types of CTR commonly available. The Maucher reform ring available in 3 sizes: 12.3 mm, 13 mm, and 14.5 mm. And Optitech ring is available in 13 and 11 mm. Selection of CTR sizes. The selection of CTR size is based on capsular bag dimensions. A larger capsular bag usually requires a larger ring, 13 mm being the most common. At minimum, overlap of the end terminals is needed to provide complete circumferential support. The size of capsular bag positively correlates with the globe's axial length. So if axial length is less than 24 mm, 12 mm CTR ring is suggested. 24 to 28 mm, 13 mm is suggested, and more than 28 mm axial length, 14 mm ring is suggested. Current capsular tension devices, there are 3 types available: standard CTR, Sionis modified capsular tension ring, MCTR, and Ahmed capsular tension segment. So indications for CTR use, basically these are indications for CTR use, not for MCTR and Ahmed segment. So evidence of, so if zonular dialysis is less than 4 clock hours, in cases of mild pseudoexfoliation accompanying mild generalized weakness, any case of suspected progressive zonular weakness like Marfan syndrome, and localized inferior zonular dehiscence or damage due to non-progressive etiology, that is trauma, can be managed with the standard CTR. Choosing a right CTD. In short, this slide summarizes that if zonular distance is less than 90 degree, 3-piece IOL or standard CTR can be used. If it is 3 to 4 clock hours, standard CTR can be used. More than that, modified Sionis ring, modified CTR is advisable. And in fibrosis of back, CTS is advisable. So function of CTR, expansion of the capsular equator, buttress area of zonular weakness, recircuit and redistribute tension from the existing zonules, recenter a mildly subluxated capsular bag, place tension on the posterior capsule to decrease incidence of PCO. Contraindications of CTR. So if there is break in anterior capsule and posterior tears, posterior capsular ring, then it is not indicated. In cases of non-continuous capsular axis, the centrifugal forces generated by the CTR may cause further extension of the capsular tear posteriorly and risk loss of CTR into the posterior segment. Sionis modified ring. The standard capsular tension ring is frequently unable to center the center or stabilize the capsular bag in cases of more profound zonular weakness. So modified capsular tension ring or Sionis ring were developed to address this issue because they can be permanently sutured to the sclera. They are indicated for the advanced zonular weakness more than 4 clock hours of weak zonules and progressive zonulopathy. The surgeon can scleral fixate the modified ring with 9,0 polypropylene or CV8 Grotex sutures. Coming to instruments innovated by our own Dr. Amulya Sahu sir for doing SICS from a 2 millimeter incision. Dr. Sahu sir's special instruments is this axis marker 2.8 mm Vectis. It is specially designed to engage the nucleus and take it out from the small incision. Then Jakobovitz nuclear fixer and Jakobovitz pre-chopper I have mentioned because sir has made some changes in these instruments, but he is using this instrument for in the back fragmentation of the nucleus. 24 gauge Simcoe cannula and fork dialer. And this is multi-jet cannula. Multi-jet cannula is a very special instrument, though it is a simple, but it is very useful to remove cortex from the endothelium and from the angle of anterior chamber and from the tunnel, and to make things easy. Sharing Dr. Saucer's 2 mm SICS video here. So after marking, peritomy is done. With crescent 2 mm incision is being made. The external lip of the incision is almost 2 mm and internal lip is almost 5 to 6 mm. So the side port is made now. Would like to fast forward a bit where few steps can be skipped and important steps can be focused. Hydrodissection is being done and nucleus. Yeah, now this is with sustainer and pre-chopper. The nucleus is divided into 2 halves. And this 2.8 mm Vectis is used to get nuclear pieces out. This way, fantastic nucleus management has been done. Next slide is showing Dr. Boramani sir's pre-chopper.
This is an axe chopper. It's like any other lens manipulator, but the tip is modified into the shape of an axe. The dimensions of this axe are 0.6 millimeters by 0.6 millimeter behind the nucleus. The axe chopper goes through the side port and the nucleus is fragmented in an almost closed and well-formed chamber.
This is the beauty of this axe chopper, that closed chamber can be, this nucleus can be divided in the closed chamber itself. So better control is available. So coming to Dr. Anil Shah sir's snare for manual small incision cataract surgery. So snare has two needles. Front needle is body. The back needle is a handle. It is done in a using 18 gauge steel needle. The tip body has at the tip it has two holes from which 36 gauge steel wire passes, and with the handle, when we pull the handle and push, the loop size can be changed. So sharing a small video shared by Dr. Anil Shah sir, showing now nucleus is already brought into anterior chamber, and using snare trisection is being done. So the one of the most important point while using snare is, if we get fear of protecting endothelium and we put too much of visco on the anterior surface of the lens, that will push the lens back, nucleus back, and it will be difficult for us to engage the nucleus in the snare. So it is equally important to put visco on the back surface as well as of the lens, as well as on the in between cornea and lens as well. There is a new modification coming in the snare. We'd like to share a small video of that.
I'm Dr. Anil Shah, presenting you a new design of snare. It has got a body which contains loop and a tail, and a handle having two screws. This is the design. Now you can assemble this snare. The body is inserted into the handle, and then the screw, the tail of the snare is locked. Now you remove the body, and then you push the handle, you pull the handle, then you can reduce the size of the loop. You can also do rotation. You can remove it and reassemble a new snare. Thank you very much.
Thank you so much. I would like to end my presentation here. Thank you.
Yeah, thank you, Dr. Arpit. That was a wonderful presentation. I think we are running short of time. In fact, we have exceeded the time.
Yes, sir. I'm extremely sorry for that.
Next presentation now. Dr. Rohit.
Dr. Arpit should share the screen first.
Yes, sir. I'm just trying to do that. Just.
Stop sharing it.
Just give me 1 minute. Yeah, is that okay? Yes, I have stopped sharing.
Next speaker is
Dr. Rohit will be talking on vitrectomy basic instruments for anterior segment surgeons.
Is my screen visible?
Yes.
Yes, yes.
Okay. Am I audible?
Yes, yes.
So at the onset, I would like to thank the entire team of International Society of Manual Small Incision Cataract Surgeons. Usha ma'am, as always, she always gives me a lot of opportunities. She's like a family. All my seniors, my teachers were present over here. My alma mater, LV Prasad Eye Institute, my teachers over there, my patients, and my family. So when we're looking at anterior vitrectomy, there are certain things which I have realized, when I interact with my phaco-refractive surgeon friends. First and foremost is we need to check compatible cutter in working conditions. Because, most of us, when I see over here in this webinar also, are well-trained cataract surgeons. So PC rent or need for a cutter is uncommon, and it may not be used for a few months or probably a year also, and that is a time when these cutters they can get rusted or they may not be in ideal working condition. So probably once in a month we can open up the cutters, check their working condition, and then repack them, ETO them. Trocar cannula recently, is also useful because the gauge size has reduced of the cutters which are available with the standalone phaco machines. And obviously, we can have the infusion or the ACN. Triamcinolone acetonide is very important to stain the vitreous. I believe that intracameral moxifloxacin needs to be injected after every cataract surgery, especially in which a rent has occurred. And light pipe or endoillumination can be an added benefit. I'll explain why in my subsequent slides. Now, different machines have different settings, but the basic objective is same: clear the vitreous safely and place the IOL. Now, what we need to understand is what kind of machine we are using. And either we have a machine which is having phaco with vitrectomy features, or it's a standalone machine. Which cutters are compatible? Now, some of the phaco machines have compulsion that the cutters are only supplied by their own company, whereas some machines they are okay with third-party cutters also, like mid-labs. Another thing which we need to know is what is the gauge of cutter which is available with a machine, whether it is 20 gauge or 23 gauge, and whether we have trocar cannula set with us, and obviously our own skill set, how comfortable we are either going anteriorly through the corneal incisions or through the pars plana route. Now, in the standalone phaco machine, I would again request, I have seen recently a couple of patients who were referred to me because the cutter conked off when it was opened months later. Needs to be in working condition, and you can keep it in an ETO pack. And we also need to know what is the maximum cut rate available and what is the gauge. Now, when we look at these two different machines, one is Laureate and the other is Legion. In Laureate, we can see the maximum cut rate available is 1000, whereas in Legion, the maximum cut rate level is 2000. In Laureate, the cutter size is 20 gauge as compared to Legion, which is 23 gauge. And we go to Centurion, it is, the cut rate is higher with 23 gauge cutter. In fact, they sometimes even give you additional trocar cannula also. And pars plana route becomes easier with 23 gauge because it becomes a self-sealing sutureless incision. And when we are doing it at the pars plana route, it is more physiological. And when you get a higher cut rate, there is a huge shift when we shift from 1000 cut rate or 800 cut rate to something like 1500 to 1800, because the turbulence reduces drastically when we have a smaller gauge and a higher cut rate. That time the collateral damage chances is more, such as creating tractions or iatrogenic breaks, or even damaging the iris. And also, if you're going through the pars plana route, 23 gauge scleral port is self-sealing. Now, this is one of the pictures of a combined machine by Appaswamy. No financial interest, but this is one of the machines which I use in my practice. Here we can see that we can easily titrate the vacuum as well as the cut rate and the bottle height depending upon the requirement. Now, in this video which I'm showing, a third-party cutter can be attached, a mid-lapse 23 gauge one. Now, there are two ends of the cutter which are there. One end we are going to attach the aspiration tubing, which I'm detaching from the phaco probe, and the you can see the other end is going to be attached directly as it's a pneumatic cutter. Some of the companies do provide electric cutter which can have a peristaltic system. This is a Venturi based system. And you can see that in the bimanual technique, we can also attach the irrigating probe over here and the cutter on the other side. In the bimanual technique, the incision size is smaller and it gives much more chamber stability. And this is the point where the cutter is attached. Instead of using the the irrigation probe, we can also use the infusion. Now, this infusion is usually available with a trocar cannula set, and this can also be used as an ACM and also can be used through the pars plana route. Now, this is a typical trocar cannula set where we can see that there are two markings, one at 3 mm, the other at 4 mm. Now, once you do the scleral markings using this trocar cannula set, you can easily enter the vitreous cavity through pars plana at 3.5 mm. Now, this is very simple. Trust me, anybody who's doing a cataract surgery, and when we don't need to do it tangentially, what retinal surgeons do, even if you make a direct entry at 90 degrees and do a limited anterior vitrectomy, these incisions are self-sealing. Another thing which I really find useful, which is also not that expensive, is dedicated anterior vitrectomy machine. Now, one of these machines is made by Reticare. Again, no financial interest. They have different levels of machine, right from something like 1.5 lakhs to 2.53 lakhs with various cut rates. This machine is the highest one, which has a 3000 cut rate. Very simple setup. Here we can see that the mid-lapse cutter is used, which is easily available to a collection bottom, no requirement of a cassette, and very versatile foot pedal is there where we can just use vacuum to remove the cortex. We can also use wet with vacuum. There is an option for reflux, and you can see posteriorly just an air inlet is used, which is from a routine oxygen cylinder, which is available in every OT. And what I was talking about is doing anterior vitrectomy through the pars plana route, where 23 gauge cutters become quite handy. And this is just one of the videos where I'm showing that you can even make a direct stab entry. Here I made a direct stab entry because I was planning a scleral fixated IOL, but a direct stab entry can be made, and see how beautifully, simply anterior vitrectomy can be done. Instead of a pars plana infusion, you can even use a ACM if you're not comfortable with a pars plana infusion. Thank you. Thank you for the opportunity.
That was a wonderful talk. He has very well explained about anterior vitrectomy for anterior segment surgeons. Yes. Any inputs from Dr. Neto?
Well, wonderful presentations, both of the The two unfortunately, due to time constraints, I would like to comment on many things, but they are very comprehensive. But I would like to stress the importance of meeting like this, that to bring attention to instruments. And I think, of course, instrument quality is essential. You must have the proper instrument to perform your task. I would say there are two sayings, important sayings that, let's say, resume this. Man is a tool-using animal. Without tools, he's nothing. With tools, he is all. This is from Thomas Carlyle. And the other one, we should say, a man is only as good as his tools. This is from Emmett Wolf. I think this resumes our thinking about the importance of having the correct tool to perform your task. And I would add that quality instruments are cheaper in the long term. Always strive to get the best instrument you can afford, because in the long run, it will be cheaper for you. And of course, it will perform your task in a better way. You'll be able to do better surgery with better instruments. I know this is, of course, we all have, let's say, cost constraints, but this is something that I have learned all of my, let's say, my professional life. And nowadays, I really strive to do that. Only get very good instruments because they are better in many ways, not only in performing the duties, but I think this should be stressed out, especially for beginner surgeons. It's important to have, and I'm happy to see that many important points were addressed in all these wonderful talks. I would like to point out one, that pupil expansion devices are really an important addition to our practice and should be used by every surgeon. I really see there is an inertia from in surgeons to begin to use them. They are very user-friendly, and they are really a game changer in small pupil cases, providing ease and safety to your surgery. So I would like to stress that as a take-home message from Dr. Shah talk.
Thank you, sir. Thank you, Dr. Netto, for your wonderful illustration about the quality of instruments and also the various types of instruments. Your skills should be developed so that you can master all the techniques, and in a complicated situation, you can handle all the complicated type of problems. Thank you for your advice and guidance also. And thank you very much for sir. Anyone wants to have any discussion? Dr. V.N.R. Siddiqui sir, please welcome. Dr. Avinash sir.
Audible, Dr. Avinash Ingole. No, Dr. Avinash, we cannot hear you.
Will be able to exchange power. And how does that work?
Hello?
Yeah, now you're audible.
Yes. Just wanted to make few points, especially as far as instruments are concerned. In India, what we get is, for example, tunnel blades. Not all of them are too sharp, some of them are blunt. So what happens when you are used to the blunt ones, immediately you use sharp ones, then there is a false entry, or maybe the outer lip of the tunnel gets torn. So that's another thing. What Dr. Professor BNR also said. Side put should be through the MVR blade, not through the flat blade, because most of the T-tears or dismissed detachment I've seen is at side port only. And nowadays, most of the SICS, they are trying to reduce the incisions as small as possible, but many times it is better or prudent to take a slightly bigger incision, especially in the harder cataracts, because what happens is the maneuverability and it's not a moldable nucleus. Soft nucleus is a moldable nucleus. The harder nuclei are quite big and they are non-moldable. Another thing I wanted to know, share some certain things, especially the CTRs. Not always you need to put pupil expanders or something. Many times even simple use of OVD can dilate the pupil. The only thing is you have to make a slightly larger axis, especially in SICS, small incision as compared to phaco, because you have to remove the nucleus out of the bag. And in order to remove the nucleus out of the bag, it has to be slightly larger opening in the bag rather than in the phaco where you're directly dealing with the nucleus. One thing I want to ask Dr. Rohit Modi, which he has presented, is there are different kind of scenarios in which you do vitrectomy, especially you already remove all the cortex, nucleus is out, and then you notice there is a PCT. Or in another scenario, there is a PCT when there is a nucleus is out, but a cortex is there. He is always telling about the past lena approach. Can it be possible that anterior segment surgeons can do only the anterior vitrectomy and put an intraocular lens? Means, can you put some light on it?
I think he's busy on the phone.
Oh, okay.
He has not heard your question.
Yeah, I think he's busy that way.
Can Dr. Avinash, can I tell you one thing?
Yes, sir. Yes, sir.
See, this small incision, those who have not done, their fear factor is there. So we are not advocating that everybody should do 2 millimeter. That is a graduation process is there. And people who are beginning, they should start with a 6 millimeter. And then as they master the technique, they can go to 2 millimeter. Because we have published papers and the result is superb. But one has to graduate to that level. So there is no question of absolute that everybody has to do 6 millimeter or everybody has to do 2 millimeter. It depends upon your expertise. And so that is why we see SICS is a very, it's an artistic surgery. It is no boundary sort of. Like phaco is limited. But in SICS, people are enjoying their journey. So like, Boramani has modulated his surgery and gives you astigmatic free. So it is all, it's everybody has their own way. So we are not talking do 2 millimeter or do 6 millimeter or do 3 millimeter. Everybody has their own journey and their own enjoyment. Okay. So because when you are giving a finality, the people who are entering, they will think that this is right or that is wrong. So there is no question of this is right or wrong. You decide according to your expertise.
Thank you, Dr. Sahu, sir. I think what you have told, the techniques done by Dr. Sahu, Dr. Boramani, then Dr. Raju Raut, the way fish hook technique or snare technique by Dr. Anil Shah, these are the procedures to be done by expertise people only. But new beginners, they shouldn't try these techniques unless they are confident and they are sure about these techniques. I think there is some learning curve for this. Everyone, if tries for that 2 millimeter, it will not serve the purpose. And what Dr. Ingule sir has said that most of the beginners must try with that bigger incision. But 2 millimeters each and every SICS surgeon. I think that can be giving best results in better hands, best hands like Dr. Amulya Sahu, and not with each and everyone. That's what I feel.
Even in a very hard cataract, also we decides the how much incision size will be. So there is no hard and fast rule.
And I think overnight one should not jump from 5.5 to 2 millimeter.
No, that is not good.
Yeah, slowly can reduce your incision by 1 millimeter each, 5.5 to 4, then 3 and 2. You can go.
Suppose I am doing a clear corneal, clear lens extraction. Why should I give a big incision? So there are situations where it is not necessary. 2 millimeter, I am not inducing any astigmatism. I will go for a 2 millimeter because clear lens extraction do not require a big incision. So we have that freedom.
Want to call Dr. Subhangi Sate for her views about this. Madam is there?
I don't think she is there.
Sir, can't see her in the meeting.
Not.
does anybody else want to comment anything?
I would like to say a few
want to
things.
mention, especially in a suspected case of PCT tear or is there any, there may or may not be. You have to reduce the bottle height, especially in case of fecoemulsification. Because once you reduce the bottle, that's what our teacher used to teach us. Water bottle, first you reduce the bottle height and then do whatever you want. But many times you forget that and the pressure inside increases, further increasing the PCT. That's it.
Yes, Dr. Manda, you are trying to say.
Yeah, a few points. First of all, congratulations to all the three presenters. Excellent presentations. One is when you choose an instrument, of course, it's important that you should be able to use it comfortably. But I think more importantly, we should be able to maintain the instruments well as well. So if you want to have a long life for these instruments, then proper care has to be taken of how to maintain these instruments, because only then can you get the desired results. As far as the pupil expander devices is concerned, there are many devices available now in the market. You can choose whichever you feel you are comfortable with. And with my little experience, I can say that I've tried all of them. But ultimately, a few things matter. One is the ease of use and, of course, the cost. Because some of the pupil expander devices which are imported are very expensive. And they can be reused with ETO sterilization, but they lose the tenacity or the strength. And one more thing which is about the vitrectomy, which I think many of us forget, because vitrectomy is not a thing which we need to do very routinely. This has been this was told by a senior surgeon many years ago. He had this practice of having the vitrectomy machine called for when it was not required. So it's like you're on a racing track, as an example. And on a racing track, you have to keep every spare part ready and in working condition. Similarly, the surgeon, without any warning, would say that I now need the vitrectomy, even if it was not required. And he would just test the vitrectomy probe. And I think what Dr. Rohit mentioned is very important, that many times when you really need vitrectomy, you find that the vitrectomy is not working and then you're stuck. So I think this one point I think is more relevant. To have that sort of schedule maybe once in 3 months or so, where you just call for a vitrectomy probe and try and do a dry run sort of, So it's like to test. You can do it otherwise also, but when you're doing surgery, then you also gauge the response of the OT staff, how alert they are and how well trained they are. Because vitrectomy is, you need it almost immediately. And once again, thank you for the opportunity.
I want to add something. Regarding the size of the incision, it took me 10 years to reduce the size of the incision from 5.5 millimeter to 3.5 millimeter. Because if suddenly we reduce the size of the incision, then we can get many problems. But if you go on gradually reducing the size of incision, then you will be adapted to the situation. Phaco is popular because it is having 2.8 millimeter incision, and SICS is not popular because it has got a wider incision. But if you slowly master the technique and if you reduce your size of incision to 3 or 3.5 millimeter, then actually you won't need a Phaco. You can do all types of premium lenses and all types of foldable lenses with 3 millimeter or 3.5 millimeter. Only thing is that you have to modify your technique. You have to adapt to the newer techniques, whatever Dr. Shaw's 2 millimeters technique or my snare technique. But if you follow this slowly, then you will find that your surgery has become more safer, and you can do without instruments, without machine also, great top job of small incision cataract surgery. And if you make an incision smaller, then actually the chamber becomes more stable and you have got more space to handle intraocularly. So smaller incision in SICS is actually more advantageous than larger incision in SICS. So those who want to practice, they can slowly reduce their incision in 1 or 2 years and gradually go to 3.5 millimeters, then that will be very much helpful for their future practice. That is my opinion.
Thank you, Dr. Shah. I have to add something. There were wonderful presentations today by Dr. Rujuta, Dr. Arpit, and Dr. Rohit. I think one important message is one of the discussants here is Dr. Avinash Ingole, who is a teacher in medical college. And there are experts like Dr. Amulya Sahu, Dr. Anil Shah. They got their special techniques. So this is the wide range of SICS. What Dr. Ingole has to see that his students, they are learning the perfect technique and from the start. One important thing is that in medical colleges, most of the times SICS is not being taught. They are directly going from ACC to PHECO. So if they are taking this step of SICS in medical colleges and PG students, I think it will be better. And the experts like Amulya Sahu and Boramani and Anil Shah, these techniques can be learned over the period of time as they have expressed. One more important thing is that I think this particular webinar was about the instruments. Though many more instruments are available in the market with the companies, I think it is a selection of instruments which is very important. And it is a problem for the juniors, which instrument to buy, which machine is to buy, because there is so much of range from about the cost, then Indian or imported, then quality. And in that case, you have to take opinion of your seniors, your colleagues, because when we were UGs and PGs, that time we used to visit various stalls and then we were discussing amongst ourselves, which is the best instrument and cost effectivity. I think don't just purchase the instrument, whatever you feel like, discuss amongst your colleagues and take the opinion of your seniors, and the utilization of that particular instrument, utility of that instrument for your technique, which is best in your hands. I think you should buy that. That's what the take-home message should be. That's what I feel. Yes, Arpit.
I think, yes.
So just wanted to share something which I learned today, apart from the discussion we had on instruments. I believe the whole society is doing a great job. And, when I think about my retinal surgeries, what I learned during my residency about SICS has helped me tremendously when I make those sclerocorneal tunnels to explant the IOL safely or to remove the foreign bodies. There are a lot of things which SICS teaches us to become a much more better surgeon in all aspects. So thank you for the opportunity.
Dr. Amir, Dr. Arti, if there is nothing else, we can just move forward.
Yes,
any questions from the chat box?
No, sir. Rajesh, sir, would you like to give, or Dr. Amir, would you like to give word of thanks?
Yeah, I think, can I go?
I mean, if we don't have any other comments or contribution from any of the participants in the webinar.
I think we've had an exhaustive webinar about the instruments. Very good presentations by each and every one of you. And I would like to thank our speakers, Dr. Rujuta, Dr. Rohit, and Dr. Arpit for their contributions to the webinar. And I would also like to thank our discussants, Dr. Neto, Dr. Ingole, Dr. Subuddhi. As always, I would like to thank our office bearers for having this platform where we can all come together and have a wonderful discussion. Last but not the least, I would like to thank Aarti for being the bedrock of everything that we do and taking the efforts every day. Thank you, all of you. Have a very
Thanks
good
to Anterior also.
Thank you.
Yeah.
Thank you.
We do have a video from Anterior to be played here. We would like Anterior to thank Anterior for supporting all our academics. Thank you so much, each one of you, for making another rocking session, adding another rocking session in the list. So, good night, everyone.
Good night. Thank you very much.
Good
Thank you,
night.
Dr. Netto. Thank you, everyone. Dr. Ingole. Thank you very much.
Thank you, Marathi sir, Shah sir.
Thank you, sir.
Thank you, Dr. Rajesh.
Thank you.
Thank you, Dr. Marathi.
Thank you, Rajesh.
Thank you.
Thank you. Yes, sir.
Thank you, sir. Thank you so much. Thank you, everyone.
Thank you, everyone.
Neto, I'm calling you. You are not able to reach you.
I'm sorry. Okay.
You're saying that it is not registered in the WhatsApp.
Oh.